So I got posted for my second year to Odisha, to a place called Bissam Cuttack that I hadn't heard about before. When I started working in the community, I had put a notebook in every village. So we have data from 94. And the infant mortality rate then was around 200 per thousand in 95.
1/5 of the infants born were dying.
Were dying within a year. The under 5 mortality rate was 350 per thousand, which means 35% of children did not reach their 5th birthday.
What are the kind of challenges you guys faced?
See, when I reached there, I was given the charge of the nursing school. Once we started the new course, the dearth of faculty, we just couldn't get people. So at times I have taken 6 hours of class a day in addition to all the administrative work.
We believe that a patient should not have to pay money before seeing a doctor. So when you enter, there is no entry fee. Our boss, Dr. Virendra Kumar Henry, a Chhattisgarhi guy who was in charge when we joined, he used to say, if I put 1 rupee as the entry fee, the man with 50 paisa will be turned away at the gate. So students very often ask us, was it easy? No, it wasn't easy. Was it worthwhile? Yes.
Absolutely.
So if your choice is between easy and worthwhile, I would choose worthwhile any day.
Hi, I'm Vallath from Azim Premji Foundation. In this show, we bring to you stories from the world of health. These are stories from the front line, stories of path-breaking work. This is the health worker. Imagine you completed your graduation and your post-graduation from one of the top institutes in the country. You can literally walk into any job in India or abroad. Instead of that, you choose to go to this distant tribal village in Odisha and spend the next 30 years of your life there. This is the inspiring story of Dr. John Oommen, MD from CMC Vellore, and his wife, Mercy John, who completed masters from the same institution. They recently retired from the Christian hospital Bissam Cuttack, and I had the fortune to spend some time chatting with them. I would like to share that with you. This is an inspiring story. So I just want to understand, after you finished your graduation, where did that take you? What did you do? What is your first placement? Johnny?
Yep. So in CMC Vellore, we have a interesting system. When you finish your MBBS, you have to serve for 2 years before they give you your final certificates. It's part of the agreement that we make when we join. So the first year of my service was at the community health hospital in Vellore itself. It's called CHAD, Community Health and Development. And so I spent my first year working in the community health department in Vellore, working in the Kanyambadi block, various villages, but also in the base hospital. I was working mostly in the base hospital, doing mostly mother and child care. So I got posted for my second year to Odisha, to a place called Bissam Cuttack that I hadn't heard about before, and to a hospital called the Christian Hospital Bissam Cuttack. At that time, it was a relatively smallish hospital, maybe around 80 beds. And I went there for a year in 1987. I totally flipped. It was everything I had dreamt about. The work was very heavy. It was busy. We were just 4 or 5 doctors, tons of patients, so much to do. And on the other hand, I could see that maybe this was what I was designed for, because there were so many people for whom so much could be done. About 80% of the community comes from the ST and SC communities. So and poverty, very few roads. Whatever development there was on the roadside. In the whole of Odisha, there are 2 blocks which had a negative growth rate between 81 and 91 census. Bissam Cuttack was the worst with a minus 10% growth rate. Chandrapur, the next block, was minus 8%. So you're looking at a place with a negative growth rate. There was no migration those days. That means deaths were more than births.
My God, you can't even imagine that today.
Yes,
right?
I couldn't imagine it either. I also joined in the end of 87 into the middle of an epidemic of meningococcal meningitis. This is colloquial language we'd call brain fever.
Right.
And people were dying all over. My guesstimate is that around 2,000 people died in a period of 3 months in 3 districts. So I was asking myself, how can there be, places where people can die like this and there is so little we can do? But I realized that if you want to make a difference, you have to get inside. Like Gandhiji said, you have to be the change you want to see. Criticism is easy.
Right.
And by the end of the year, I was more or less convinced that this is what I want to do with my life.
What about you, Mercy? You completed your graduation, and then what happened?
Not knowing where to go and what to do, I just continued there. Funnily, in our fourth year, our batch was asked to go and survey one entire strip of area, to go and stay there for 1 year, to cater to the students who were coming, so that they could learn how to conduct deliveries at home.
So let me ask you this: did you think this was a punishment at that point in time?
I was actually a little
Somebody's
irritated.
out to get me.
I was wondering why did that happen? And so I said, see, we've just finished our labor room posting and everything, and now next month I'm sent here to go and do this and conduct the deliveries. We didn't know a single soul there in that. We have to go and find out who the pregnant women were. Plus, after coming from a tertiary level setting, now I have to conduct deliveries on the floor with minimal equipment. It was like completely different. And anyway, the confidence level was very low because I did not know. We as students, there's always teachers around us when we had to conduct the delivery. And now taking all the decisions by myself, if there's a complication, it's going to come on my head. So I was sent for training, and actually he was the one who trained me.
Oh, Johnny. That's when the sparks happened. Huh?
No. Sparks
Nothing happened.
came much later. But yeah, I mean, that's a bad place to start romance, in a labor room.
Okay,
So you are
then
saying that labor room, nothing happened, but you are just training her.
Because we knew that the kind of life we were looking at required a partner who would be thinking in the same direction. You need a kind of commonality on your attitude to work.
Right.
You need a commonality on your attitude to money.
Right. That's a
Critical
huge,
ones.
huge one. Actually.
It's a huge one. And your willingness to take risks and go out and do stuff. And we suddenly realized we were actually looking at the same thing.
So can you just describe what the place was like? The people, the kind of facilities which are there.
So it's a small place. Even now the population is a little less than 10,000. 9,000 is all that we have in the village. We are located very, very far away. It's 400 from Bhubaneswar, 250 from Vizag, 350 from Raipur.
Okay.
So those are the three cities if you
Three
took
big cities,
markers.
actually, yeah.
And as a hospital, if we wanted to refer patients to a hospital which can do more than us, it is Vizag, Visakhapatnam 250 kilometers or Berhampur 250 kilometers.
Okay.
The buck stops with us practically. So Bissam Cuttack block consists of this main village, if you like, Bissam Cuttack village itself, which is around 9,000 population, and then around 314 little villages
Okay.
scattered across the hills. Like I said, if an area can have 2,000 deaths due to meningococcal meningitis in 1 year, in 3 months, it's a sign of how bad it is. So usually when you have populations like this, you have what we call high fertility, high mortality.
Okay.
So the birth rates, if I go back to around 93, the birth rates in our communities which we serve, about 50 villages, was about 30 per thousand, when
okay.
the national average would have been around 20 per thousand.
Okay.
And the death rate similarly, while the national average would have been somewhere around 10 per thousand then, the death rates were closer to 20 per thousand.
That's
So lots of
double
births,
that,
lots
yeah.
of deaths.
Lot of deaths, yeah.
And when I started working in the community, I had put a notebook in every village. So we have data from 94. And the infant mortality rate then was around 200 per thousand in 95.
1/5 of the infants born were dying
Were dying within a year.
within a year.
And the under 5 mortality rate was 350 per thousand, which means 35% of children did not reach their 5th birthday.
More than 1 in 3 children died before they were 5 years old.
So if you wanted to have 2 children, you'd need to have 3 or 4, basically.
Yeah.
That's why you have
That's
high
why the
fertility.
high birth rate. I'm sort of jumping ahead of myself, but what is the percentage now actually?
So against an infant mortality of 200 per thousand, now it'll be closer to 50. Against an under 5 mortality of 350, now it'll be closer to 80. I've seen, we were lucky because we were there for 30 years. We were there long enough to see change. Most people don't get the chance to see the change, but we've been extremely privileged. A lady doctor from Denmark came out in 1954, having heard about this area where people were dying, and she started health work. So this hospital started in 1954. She began very small, just seeing OPD patients, and then there was a patient with burns. You couldn't just give an injection and send away. So her staff quickly put up bamboo poles, made a little hut. That was our first ward. So it started, totally built around one stubborn lady. In between, she fell sick. She had to go away. The hospital shut down. She comes back, restarts. So it was a very shaky kind of a thing when it started.
Right.
But across the last 70 years, it has grown from there to what it is now, where we call it a 200-bedded hospital. We've had times when we've had more than 250 patients admitted. But if I look at 16 villages where we've started a tribal school, the female literacy rate in 1997 was 1%. That's the indicator we use.
1%?
1%.
My.
Today, it will be somewhere around 45-50%.
In Bangalore, we have a problem. We go to a nice multi-specialty hospital. There are enough doctors around and all kinds of equipment and infrastructure. How is it running a hospital and a community health work in a place like Bissam Cuttack?
Yeah, that's a really good question because Bangalore and Bissam Cuttack, as far as healthcare is concerned, the rest of India you can put between the two. So what does it take to run a hospital in such a place? One, you have to define who you are, why you are, and who you're trying to serve. So we were very clear. We are a secondary hospital. We do primary care and secondary care. Bits of tertiary will leak in, but that's okay. Two, we are primarily here for the poor. And if the poor cannot come to us, then we have no rationale in being there. That then governs the way we build our buildings, the kind of specialties you start, the way you cost things, everything comes from that. So we have outpatients and inpatients. In most hospitals, the outpatients will be 5-10 times more than the inpatient numbers. Ours is 1:1. Because outpatients is something that even a government hospital can do.
Wow.
Inpatient is where there is nowhere else to go.
Okay.
And therefore, this hospital is now 200-bedded, 5 operation theatres, labor room, a small ICU, of course the emergency department, the outpatients, a college of nursing, an English medium school on campus without which you won't retain staff, the community health program, and so on and so forth. All this together is what we're calling Christian Hospital Bissam Cuttack. So the second lesson in this which I had put to it is, if you want to make a difference in a small place, you can't stick to what your qualifications are. Yeah. You have to do what needs to be done. That is even true for the HR. So as doctors, you might have one pediatrician, one gynecologist.
Yes.
But their job is to teach everybody else what they do. Because otherwise, when they take leave, people are going to die. So you have to learn to multi-skill, multitask. That's part of the deal. You learn to work with many things. Equipment. So what drives cost of healthcare? For us, keeping the cost down is very, very important.
Right.
So what drives cost of healthcare, in my opinion, is one, doctors' expectations of salaries, because that benchmarks everybody else's salary.
Yes.
And two is the amount of technology you want to get into. This automatically raises costs from AMC, CMC, the works.
Right.
So if you got a handle on those two, you can keep your costs down. And money should never be a barrier. For example, I'm sure you don't have a hospital in Bangalore like this. We believe that a patient should not have to pay money before seeing a doctor.
That's amazing.
So when you enter, there is no entry fee. Yeah, because our boss, Dr. Virendra Kumar Henry, a Chhattisgarhi guy who was in charge when we joined, he used to say, if I put 1 rupee as the entry fee, the man with 50 paisa will be turned away at the gate. And if you look at any healthcare organization, generally a secondary hospital, 45% of your expenditure will be HR, salaries. So as a hospital, our highest to lowest salary scale ratio is 1:5.4. Yeah. We said that if the cleaning staff gets 10,000, then the cardiologist cannot get more than 54,000. You want to give the cardiologist 110, and then you give the cleaning staff 20. No? This, yeah. So all these crazy ideas are built into the model, and it works. 70 years, we are still alive and running. Our argument is patient care must produce the operating costs. For capital costs, you beg, borrow, steal. Wherever you get the money, you do it. Don't burden the patients with that. and we are able to actually balance off. The critical limitation will always be human resources. So getting doctors, we produce our own nurses better than anything in the market. Our College of Nursing nurses are any day head and shoulders above what is available from outside.
I want to understand about the community work you were doing, because I think that was very powerful, right? I mean, that is what really uplifted the lives of the people. And
So when we joined in 93 and I joined the community health department, there were already existing programs of these sorts, smaller, some things happening. And for me, the most important part was to become part of the community. So it was very important because, we sometimes define development as trying to make other people like ourselves. And
Right.
we go and then destroy a culture which has kept them alive for 1,000 years.
Yeah.
So I was very keen that we must not do anything which damages. There was one particular village called Kachapaju. That's my favorite place on the face of the earth. This village is hatke, different way of thinking. So when I asked them, what is it? This is May 1997. We are sitting in this village. We are asking, what is your dream? One guy says, one day there will be a collector from our tribe.
Wow.
There's God and there's collector. Nobody's sure which is higher. And then somebody else says doctor, engineer, teacher, nurse, driver, forest guard. They went through all the ones they'd heard of. At this stage, there had been only one boy in that village who had ever done 10th standard in history.
My.
In their group of 16 villages, there were 2 people who had done 10th standard in history. So they were saying these things and I was writing it down. The leader of the village is a man called Yudhishthir Saraka, amazing person. He said, everybody shut up. These are all stupid dreams. He said, every single dream you are enunciating depends on education.
Mm-hmm.
And we have a government school in our village since 1972. The teacher comes 3 times in a year. Independence
3
Day,
times in a
Republic
year.
Day and Saraswati Puja.
And there's one teacher.
Yeah.
Okay.
Education doesn't happen. So he said, with this kind of a school, the maximum you can become is a peon if you study hard. So don't create dreams that can only lead you to disillusionment. So then everybody keeps quiet because the elder has spoken.
Right.
Then he turned at me and looked at me and said, where did you study? Tu kutta podlo. It's like me engada padche. Tu kutta podlo. Where did you study? You don't look like you studied in a school like this. So I said, correct, I didn't study in a school like this. He said, what kind of school did you study? So I said, private. He said, what is private? So I said, well, if it's not run by government, it's called private. He said, is that allowed? I said, yeah. He said, write that as a dream.
Wow.
So basically, he said, give us a school like the one you studied in. He said,
got
give
to
us
the
a...
root of the problem, actually.
He caught on.
Yeah.
He forced us. He said, give us a school where our children will study and not be ashamed of their parents.
Wow.
A school that is true to the language, the culture, the religion of the ethos, and the ethos of the Adivasi people. If you'll give us that kind of a school, the rest of the dreams can come true. And the whole village got so excited. I got scared. I was terrified because our entire budget then was 5 lakhs.
No, and not only that, you are a doctor.
And you're a doctor.
They're asking you.
There's no way we could do this. So I kind of put my tail between my legs and withdrew from that village, quietly ran away. But within 1 year, the school started.
That's the power of a vision, right?
It is. Within 1 year, the school started because they formed an association of 16 villages. It's called the Malkon Anchalika Sangha, the Hill Tribe Area Society. And they said, we are starting the school together. 2 families, including the leader's family, gave land. All of us worked. Nearby villages made raw bricks, 500 bricks per family. The rest of us did manual labor for 2 months.
Wow.
We had no money for cement, so it was mud mortar and mud brick. And we named the building Mahatma Gandhi Building.
Wow.
And we called the school the Mitra Residential School, Kachapaju. It had to be residential because the villages are too far apart in the forest.
What a tremendously inspiring story.
And
yeah.
in 98, we started.
So I just want to understand now, looking at the other side, what are the kind of challenges you guys faced?
So, see, when I reached there, I was given the charge of the nursing school. Challenges, there has been, of course, once we started the new course, the dearth of faculty. And we just couldn't get people. There's no way we could get people to teach. So at times I have taken 6 hours of class a day.
Wow.
In addition to all the administrative work. The other 2 were also busy.
Right.
But we could not run with just 3 of us.
3 of you,
we
yeah.
needed so many more. We definitely did get few people come and go, but that wouldn't help. So then we had to plan that we produce our own nurses and then send them up for training and then bring them back. So all that involved a lot of planning, a lot of thinking, conceptualization, and with the concept we also have to do it.
Right.
So it is that we are the boss and the peon and everything together. There's no separation of one with the other. In addition to the actual groundwork of taking classes, teaching, no office assistant.
Oh,
So all that also.
yeah.
And then when we get these ideas, when there used to be, resistance, no, it can't be done, there are no finances.
Right.
Yes, we were a small hospital, we were a small institution. But if we don't spend, we can't reap the benefits either.
Absolutely. Yeah.
So then, in my desperation, one day I wrote to one of my friends, very close friend who was in the States. And she just promised me, you said, you do what you want. I'm sending you the money.
Wow.
Which, gave such a relief. Then at that point, I didn't have to ask anybody because the money was coming for what I wanted to do. And then I could do things like, selecting people, talking to them, motivating them to send. And then the next big barrier would be for them to get the seat.
Yes.
We can
You
tell
have to train
everybody
them up
wants
to-
to go to
yeah,
Vellore,
yeah.
but it won't happen so easily. And what I many times thought was, I had three things going against me. One was that I'm a woman,
Yeah.
and people generally tend to listen only to males.
Unfortunately, yes.
And that was on the work front, where personnel. So everywhere I went, I'd be trying to motivate people to come.
You actually had to start this entire College of Nursing from scratch, right?
Yes.
That must have been a terrific experience, actually, right?
Yes.
Terrifying in some sense, but terrific also.
Yeah. Then another thing was, of course, a lot of learnings have happened, a lot of privileges have happened just because we were there in that place,
Right.
which wouldn't have happened if
You were in
we had
Vellore.
continued to be in Vellore or some other big place, just because we were in that small place.
So we talked about challenges of this nature. I want to also talk about challenges in terms of the in a community like that. I'm sure there must have been epidemics, pandemics, serious health issues in the community work you must have faced. Can you talk about a little bit about any of those challenges that you all faced?
You're talking about
Professional, yeah,
in the villages.
in the villages, yeah.
Yeah, lots. Each of those actually changed directions.
Okay.
So in 95-ish,
hmm
I was in the field every single day. I'd start out in the morning at 7:30. I'd come back maybe 8, 9 o'clock in the night. The hospital had only 2 jeeps. It was drop us at one point in the morning and pick us up in the evening. So we walked. We were a team, 3-4 people together. One nurse, me, a couple of people from the community. Knapsacks, bags. Now we were training village health workers. A tribal woman from the village who the village would choose, we would train so that she could do basic things. One particular health worker, her name was Runa Kolaka, extremely smart, very, very intelligent, not been to school. So I had trained them on deliveries. And I had trained them that suppose a patient delivers and the placenta doesn't come out, they'll bleed. So what do you do in a village? All kind little things like this, what you can train, I had trained her. Now she was pregnant. And so she asked me, will that happen to me?
Okay.
And I said, no. She says, will I die? I said, don't be stupid. And then she said, if I call you, will you come? I said, yeah. I was here to save the world. I was young, brash, arrogant. So I said, sure, just call me and I'll be there, kind of a thing. Now, when she was just 32, 33 weeks pregnant, I was in her village one Thursday. I had examined her on her veranda, checked out everything. Everything was fine, explained everything to her. And I had told her on Tuesdays, I go in this direction, Wednesdays this way, Thursdays this way, and I went off. The next Tuesday, she went into labor way ahead of her time. And just like she said, the baby came out, the placenta didn't. She bled. Her husband was a very simple man. She told him, go and call, there's a PHC nearby. go to the PHC. PHC was locked. He came back. What do I do? She said, go phone. Solar phones, this was July. Phones don't work. He came back. So she said, go to the hospital and call him. Call Johnny.
Okay.
This is 23 kilometers. He walked. By the time he reached there at 1 p.m. in the afternoon, I was away in some village.
Oh my.
Mercy saw him.
He came there. He talked to us.
But she asked him, what do you want? He said, I will only talk to sir.
I want Dr. John.
Oh my.
These were the days when the tribal people didn't trust anybody else.
Oh my.
By the time I got home, it was 8 o'clock in the evening. He's sitting there. I said, Krishna Konala, what happened? He said, Runa is calling you. So we turned the jeep around and went. She had died around 2 o'clock.
Oh my God.
She was lying there. It was dark. There was no electricity in those days. I could hear the crying from long before we reached. Everybody's sitting around her. She's in the dark and she's crying. And everybody's crying. And they haven't cut the cord. The child is still there alive between her legs. So I said, why didn't you cut the cord and take the baby? They told me before she died, she said, Dr. Johnny will come.
What a heartbreaking story, Johnny.
I sat there and cried. Because that's all you can do.
I'm going to cry listening to this.
I just sat there and cried my guts out. I think crying is very good for our souls. Because I realized that my MBBS MD was not enough to save my health worker's life in delivery. So this actually broke me. I almost gave up at that point. And later as a team, when we discussed this issue, why did this happen? We said, why did Runa drive? You use the root cause analysis methodology, Why? And one of the answers to the why that came was she died because her husband wouldn't talk to anybody else. Mm-hmm. And why is that? Because everybody depends on Dr. Johnny. And why is that? Because that's the way he works. My team told me this.
Okay.
So that made us change strategies. I had to step back, stop making everything personal, train others. We did lots of things. Our nurses didn't have a uniform in the community till then. We made green uniforms for them, green saris, so that even if the girl inside the sari changes, everybody knows the green sari. And you had to broad base the trust.
Yeah.
So it changed many things for us. There are incidents like this that actually change your entire direction.
Thanks for sharing this. It's a very difficult thing to share.
Yeah, it was. It took me a long time to process that. So things like this, there have been many, many things. Like I was telling you earlier, the single biggest disease we had in our area was malaria. Malaria, public health people think that the bulk of it is in Africa, but there are parts of India which behave just like Africa. The amount of malaria we had in our area is not covered by the terms endemic and hyperendemic and holoendemic. This was beyond that. We tested all our under 5 children in 2010, and out of 1,245 children tested, 730 were positive in season. That means 59% of children were positive for malaria with or without fever, mostly without fever.
Wow.
So you're talking about huge amounts of malaria. Now, the national program would only talk about giving chloroquine and DDT spray.
Yeah.
That's grossly inadequate. So we had to apply our minds. And tribal families are just perfect for malaria because the clothing, the housing is very mosquito friendly. So we needed a strategy that works for our people. So in 96, we started what we call the People's Movement Against Malaria. Mm-hmm. Empowering individuals and communities with the tools and knowledge necessary to control malaria in their villages and their homes. We used neem oil as a repellent. We used medicated mosquito nets. And we used chloroquine for treatment in those days. We had a sharp fall in malaria. So in 2010, in our 50 villages, it was 59%.
Okay.
The next year, it was 33%. The next year, 27%. The next year, 12%. The next year, 15%.
Wow.
And if you looked at under 5 mortality, all cause, it follows the same graph. In other words, in our area, if you decrease malaria, you decrease child mortality.
Wow.
Now, we took this data and presented to the state government quietly because both of us were consultants for the state government. We presented it to them. We were also looking at the link between malaria and malnutrition. Mm-hmm. We found most of our malnourished children had chronic malaria. You treat the malaria, the weights increased. We made a word, it's called malaria-induced malnutrition. So all this data we put together and kept presenting to the state. Initially, people laughed at us, but finally they caught on. And this then was taken on by the state government of Odisha. We had some excellent health secretaries, Arti Ahuja and Pramod Meherda. We had Dr. Madan Mohan Pradhan, who's a brilliant malariologist, he led the program. The two of us sat down and wrote the strategy together. Government of Odisha funded it, and they ran a program called Daman. Daman Odia means pressure, but it also means, it's an acronym for Durga Manchildra Malaria Nirakana, which means eradication of malaria in remote areas.
Okay.
What happened was amazing. It's never happened in the history of malaria. In 2017, while the first 6 months malaria in Odisha was higher than the previous year,
Okay.
from July it falls sharply. The graph is amazing. It falls sharply. By December, it was 80% less than the previous December.
Wow.
And it holds through 2018.
So it went down to 1/5 basically.
Yes. And this was so huge that the World Malaria Report 2018 actually mentions that Daman was a new strategy. There's a movie called Daman now. But this idea came out of, what I'm trying to get to is,
The seed is.
what I'm trying to get to is, we have the opportunity to work on the ground to create ideas. The idea, while we create it, was meant for 2.5 villages, might have a relevance, so the larger meaning in the little things we do.
Yeah.
That's what I'm coming to. So these have been some of the good things we saw happen. And we've contributed to the whole science of community malariology in that sense.
We did everything we could possibly do in our setting to keep our, our motto was the best possible care, safety for
All.
staff,
Yeah.
safety for all staff and the patients, and what we could do, we would do. And that's what we did.
And at low cost, sir. Very low cost.
Yeah.
1,000, 2,000 per day was what it was costing us for severe COVID.
Wow.
We were able to do it.
So whether it was, turning the nursing college into a tailoring and designing unit, we put everybody into scrubs, all the uniforms off, making our own UV lamps for disinfection of the...
That's truly innovation, yeah.
Yeah, we did a lot of innovation.
Yeah.
In COVID, we did a lot of innovation. We discovered we were capable of stuff.
Less than 1% of the people who were in your position when you graduated would have taken a step like this and dedicated your life to something which most people wouldn't have even thought about. So what is it that you can give as an advice to somebody who's a young graduate passing out, graduating from college?
One thing which I tell my students, see, when we learn nursing, we learn so many procedures, all our procedures, injections and the temperature and all these things which we learn in our hospital is directly on patients. And which kind of patients? General patients.
Much larger percentages anyway, general
Yeah.
patients. Yeah.
So our actual learning has come from the poor. What right do we have to say now I have to fill my pocket?
Mhm.
And that poor person is paying the bill also. Not only are we learning, they are paying their bill also.
Right.
For a nurse, you can get a job anywhere in the world. What right do we have to say, now I've got my degree, now I have to go and, build my
By
house?
just training yourself to look
Yeah.
at what you're grateful for
Yes.
and then focusing on that, I suppose, right? Awesome. What about you, Johnny?
Yeah, so I was just trying to think through your question. When I look back, I think our work, if you try to summarize it, I think our contribution has been to building people, to watch people grow, to evolve ideas to a point when it can be transferred to something else, and in the process to build institutions, not only our own, but other institutions as well.
Yeah.
To anybody who is wondering what I should do after I finish, medicine, nursing, whatever, what I think we'd like to say is that we sacrifice nothing. People keep thinking that we sacrifice stuff. It isn't true. My dad used to say, you have to sacrifice your sense of sacrifice. We gave little, we received much.
Not much.
So that's an investment. It's not sacrifice. Reality is, that we have received far more than we have given. See, you train to be a doctor, you finish your MBBS, you go and work. At the end of time, what do you want anyway? Yeah. I find it crazy that people want to spend their life earning money more than they can ever spend.
Yeah.
So, students very often ask us, was it easy? No, it wasn't easy.
Yeah.
Was it worthwhile? Yes.
Absolutely.
So, if your choice is between easy and worthwhile, I would choose worthwhile any day.
Absolutely. Yeah.
So, at the end of this, we've just retired and we are just looking back right now and working away. We're retiring, putting on new tires. There's more journeys to run. But looking back, we have received more love than we ever deserved. When we were leaving Bissam Cuttack, the railway station was packed with people who had just come to say goodbye.
Wow.
The amount of love we have received is unbelievable. The satisfaction we have that we have been lucky enough to see change.
Right.
We've been lucky enough to see people grow and take over from us. Thirdly, the fact is that we were only a very small part of a much bigger picture. The story is not about us. The fact is that there were so many people who are part of that story. The staff of the hospital, community health, college of nursing, the community, the people of the Bissam Cuttack town. There are so many people who are part of that story who have as much right to the credit of the story as we do. We were just one small part of a bigger story. For the Christian Hospital Bissam Cuttack, we've never had the time to make a vision mission statement. We're just too busy with work. But we try to put down what we think is the core, and that's what I tell medical students wherever I go. The core of what we're trying to do. We say, one, share the pain of your patients.
Mm-hmm.
You can't just prescribe healing.
Right.
You get inside.
Yeah.
Share the pain of your people. So our calling, we say as a hospital, our calling is to share the pain of people. 2, to respond and serve with love. And 3, to be the change we want to see. That is our threefold motto as an institution, which we have evolved out of working and learning. And so to the medical students, nursing students coming out, that's what we need to say. We owe it to our patients. We owe it to our country. Not out of pity or not out of sacrifice. Share the pain of people. Respond with love, with dignity, with respect. And be the change. It's easy to criticize. We just have to live out that change. To me, that's what I'd say to any young person today. It's just worth it. It isn't easy, but it's worth it.
Thank you. Having spent 3 decades of their life in a tribal village in Odisha, Johnny and Mercy don't feel that they sacrificed anything, because they feel that what they received in return is far more than what they gave. In terms of their learning, in terms of their satisfaction, in terms of the impact they could make, and most importantly, in terms of the outpouring of love they received. So here is hoping that many more health professionals follow in their footsteps. This is The Health Worker.